Good afternoon, everyone. I am Becca Cotto, the Director of Community Engagement here with YWCA Delaware. We're going to get right into it because we only have 60 minutes and we have an amazing panel. We're going to start with Mariann Kenville-Moore from NAMI Delaware. Amponsah, she's the DV and Community Health Program Manager at DCA DV, and Andrew Ramsaran, who is a DV and SV counselor, and Lauren White, who is YW's legal and medical service trainer, and Andrew's with YW as well. So thanks for being here. We're going to start with Amma, and we're going to go to how do we define mental health in the context of trauma, particularly for survivors of domestic and sexual violence.
Thank you, Becca. And so I think when we talk about mental health in the context of trauma, especially for survivors of domestic or sexual violence, we're not just talking about the absence of any illness like anxiety, depression, or any other diagnosis. We're really considering how mental health is about a person's ability to stay safe in their body, to manage their emotions, and to connect with others, and also to make choices that give them a sense of control over their life. And so with survivors, those things can be deeply affected by their experiences of power and control and harm. And we know that trauma can change how someone sees themselves, how they see the world, and it can make their safety feel uncertain and feel risky. And so when we think about supporting mental health in this context, we're really talking about creating conditions for safety and empowerment and connection. And it's about really recognizing resilience, honoring their choice, and understanding how healing doesn't look the same for everyone and how it's a process. It's not always going to be a quick fix.
Thank you so much for that. And thank you for being here, all of the panelists. I did forget to thank you. Next, Lauren, what are some of the most common mental health challenges faced by survivors of DV and SV?
Thank you so much.
Sure.
How each person responds to trauma varies greatly based on a lot of factors like their support systems and their past traumatic experiences and things like that. But even though every person's struggles and healing process might look different, a lot of survivors do share that they have common experiences. Many victims of domestic or sexual violence develop post-traumatic stress disorder, depression, and/or anxiety. People also report experiencing dissociation, difficulty sleeping, nightmares, and flashbacks. And a lot of times, the feelings of loss and of safety and lack of control leads to behavioral changes as well, like hypervigilance, isolating themselves, disordered eating, self-harm, and substance abuse. So it can have a very wide range of.
Yeah, that's a lot. That's a lot. Thank you for that answer. Mariann, what are the long-term psychological and emotional impacts of experiencing DV or SV, particularly during childhood?
Thanks for that, Becca, and for the opportunity to be with you. As we've heard from Amma and Lauren, we understand that domestic violence and sexual violence can be traumatizing for people. I say that because trauma is one of those things that is experienced on a continuum. And so we also know that one person's experience can vary very differently. And Lauren described what some of those factors are. And so we know that the short-term exposure to violence has these psychological impacts, but the exposure to that kind of stress can also create circumstances in which someone's mental health might get even more triggered and exasperated. So the person perhaps has had some episodes of anxiety or depression in the past, but now an experience that was contained during a few months of their life is now becoming a regular experience. the ability to emotionally regulate can become more difficult. And you asked about the childhood piece, and the other thing that we know is that we've learned this over the last 25 years. We've gotten some really good research and understanding about what these long-term impacts are. But we know that when children have what is called adverse childhood experiences, that it places them at greater risk of developing mental health conditions and challenges later on in life. And so there might be some genetic markers that predispose us to have anxiety, depression, bipolar disorder, schizophrenia. But when we have childhood experiences that create stress and chemical reactions that might trigger genes, we really are learning a lot, that you have that greater likelihood in long term, which is why that early intervention and prevention piece is so important. We know that recovery is possible for people who experience these things. I've had the privilege throughout my career to work with people who are extraordinarily resilient and are able to connect to their support networks and systems. And so what we try to do is talk about what these long-term impacts are, but we also work not only in our programs, but in our communities to offset that childhood exposure to try to help children who might be experiencing it now have better outcomes longer term. But those long-term psychological impacts are real.
Yeah, thank you so much for that. Andrew, your capacity as a counselor, how does sexual assault uniquely impact a survivor's sense of safety and self-worth?
All right. So yeah, so the violence of a sexual assault is it's more than just the physical attacks effects because violations against a survivor like include breaching basic rules of how we treat each other as human, right? We expect others not to abuse power dynamics and respect our bodily autonomy. So when assaulted, a survivor's understanding of human relationships, including their like basic sense of self, is shaken. For example, survivors will often lose trust in themselves as they question what they could have done to avoid the assault. And these messages are also amplified by the systems and society in the aftermath. And that's why building back simple positive connections to the self and others is unique, and it's often a necessary part of the healing journey after a sexual assault.
Thank you for that, Andrew. Really important. Um, so, Lauren, how do generational cycles of domestic violence and trauma continue within families, and what can be done to interrupt them?
So a lot of times what happens is that when children grow up in a home seeing violence either towards themselves or between their parents or and their partners, they can start to view that as a more normal part of relationships and as a way to express themselves. And it both really normalizes them seeing that violence is both a way to get what you want from someone, and also that violence against themselves in a loving relationship is something that's okay. So then as they get older, a lot of times people end up replicating the same patterns in their own relationships, both as perpetrators and as victims of domestic violence in their adult relationships. So in terms of what can be done to interrupt them, there are a lot of different systemic changes that would be amazing. But a few things would be just teaching healthy relationships outside of the home and schools and clubs and things like that. Because not all children are going to have a healthy home relationship to look at. So giving them more examples and teaching them what a healthy relationship looks like in other places is really important. And then also a lot of times people with young children are unable to leave the relationship because of the lack of services available or concerns about custody or not wanting to bring their children to shelter, all different kinds of things like that. And that often ends up with the person staying in the violent relationship and the child being exposed to violence for longer. So I think the other way to interrupt kind of the generational cycle of it would be for there to be more services and support for people with young children who are trying to leave violent relationships.
Thank you. It's going to ask a follow-up question, but it might come up, so I'm going to hold it. So, Amma, are there racial and cultural disparities in access to mental health and trauma-informed services for DV/SV survivors? I don't mean are there. Could you talk to them? Because we know that there are.
Yeah, of course. And so, like you said, we know that there is a disparity, and we know that Black, Indigenous, and other survivors of color often face greater barriers when accessing support. Some of those barriers can include that lack of cultural responsive services, um, language access issues, fear of mistrust of systems based on historical and ongoing discrimination, and then also maybe limited representation among service providers, right? So that can also create a lack of trust. And so these root causes are complex and interconnected. Um, we can think about how structural racism, economic inequality, and all of the ways of how that bias and stigma might show up in our systems. And so that can end up turning away a lot of survivors or making them feel like they wouldn't be able to receive adequate services and can turn them away from seeking services altogether. Um, and so I think as we start to understand that as service providers, we can be more understanding when we encounter survivors who might be experiencing and needing mental health support, right? So being more empathetic in our approach and being more understanding of the barriers that they had to face to access the services in the first place.
Yeah, people first, right?
Yeah.
It's kind of like housing first, but people first. Thank you for that, Amma. We're going to hot topics real quick, and we're going to talk about mandatory reporting. So, Mariann, could you explain mandatory reporting for those that don't know what it is, and what the greatest challenges are with informed consent in mental health and survivor services?
Yeah, so this is a great topic, and I love the opportunity to talk more about mandatory reporting statutes because they've been around for decades. They started in a variety of states in the 50s, 1950s that is, and 60s. And so they've existed on our books for a long time. But unfortunately, many people in the community and public really don't understand entirely about their rights to privacy and confidentiality. And so as providers, we find ourselves frequently being on that front line of trying to do that education. And at NAMI Delaware, we offer education and support to families whose loved ones are experiencing mental illness. And so engaging with medical providers and mental health providers is something that they frequently do, and so it applies there. And so mandatory reporting are generally statutes that acknowledge that people have privacy rights, but there are exceptions and limitations to that. And frequently in states, those limitations apply to children under the age of 18 or who haven't been emancipated by the courts. It includes individuals who have limited capacity, have been deemed to be perhaps incapable of caring for themselves and making decisions. It also can be individuals who are over a certain age. So in Delaware, for example, individuals who are 62 and older are defined as seniors. And so if a senior is subjected to maltreatment or neglect, there's a requirement for mandatory reporting as well. And so in Delaware, I got into it a little bit, but in Delaware, we've established these limitations, and we've also now expanded it to include reporting cruelty to animals as well. And so there are a number of statutes in Delaware, but the ones that oftentimes we as mental health providers or mental health providers in general in the community engage in are these mandatory reports of abuse and neglect and exploitation for children and for seniors and for vulnerable adults. And so for us as a field, what we really encourage people to do is to use best practices and to assume that the people that we're working with and we're meeting don't necessarily have a full understanding of their rights and protections. And so that before we engage and work with people, we work to build trusting relationships. And trusting relationships means that you have to be honest and share information with people so that they can have an informed process in talking with you. And that's easier than it sounds, because sometimes when I pick up a phone, I can have people who immediately start sharing details with me that perhaps raise flags for me. Do I need to make a report at this time? Do I even have the ability to do something like that? But then there are ways that we can, in our practices, ensure that we are following protocols that initially talk about the importance of addressing people's rights and the requirements of mandatory reporting. It is a real difficult issue here in Delaware because, again, Delaware has a very broad statute specifically related to child maltreatment. In some states, every state have these statutes, so this applies across the board for the most part, but some states limit that mandatory reporting to certain types of professions. But in Delaware, everyone's a mandatory reporter. And so the challenge really is to try to help the people you're working with to know what the limitations and what your obligations are before you engage people into services and support, so that your relationship is as transparent to begin with as possible. So that if people begin to talk about areas of reporting, that it doesn't seem like such a violation of our privacy and trust that I now have to interrupt you and say, oh, wait a minute, I think I have to make a report on that. And there's some really good practices that people should incorporate into their work. Again, making sure people understand what the limitations of privacy and your obligations are. But also, if someone does disclose, getting back to Lauren's and Andrew's point about empowerment and giving people back agency, not every report is life-threatening and immediate right now. Many of the reports, especially for those serving adults, many of those reports are very delayed reports. And so being able to help that person in that moment understand the requirement for mandatory reporting, perhaps helping and empowering them in being part of that, is really important to a therapeutic and productive relationship moving forward. You know, many of us who practice in this area have had to assist people in making those mandatory reports. I can assure you those reports go in better and with more responsiveness or lack of responsiveness, frankly, from the systems than if they were made by some anonymous person. And so the real trick with consent and mandatory reporting is trying to help people understand what the limitations and what their rights are. Again, giving that control back to them, helping them, because when people have those experiences early on, if they go well, if perhaps you have to call in a report of an experience of child abuse that occurred decades earlier, if you have that transparency, that connection, you're less likely to have problems come up unexpectedly in your treatment relationship with a person. And so it really can, if it's done well, can really set people on a course towards healing. But if it's done poor, result of having people recanting. And that's actually what we see a lot of times with children. More and more, we have mental health professionals and other professionals working with youth in our school systems, in our communities. And those individuals also have mandatory reporting obligations. And children are less likely to understand privacy and confidentiality and reporting. And so they may disclose things that need to be reported, but because they also lose control. We continue to see in research and studies recantation, and that really impacts people's ability to get help and the support that they need. I know that was long, Rebecca.
No, but it's really important because it's like the trust is the basic thing there. And the experience, you're right. If the first time you enter into this to get counseling and you have a horrific experience, might be the last time you go for help. So thank you so much for that. Andrew, what are some effective therapeutic approaches for supporting survivors of DV and SV?
Yeah. Well, through the YWCA Sexual Assault Response Center, we provide some of these helpful approaches. For example, in individual counseling, we provide trauma-focused cognitive behavioral therapy, and that uses what we know about trauma's effects on the brain to help survivors connect their experiences to their thoughts and their actions and understand where they can help make helpful changes. Somatic therapy does similar work using awareness of bodily sensations and experiences. Support groups are another important piece because they give survivors connection with others going through similar experiences in a supportive environment. And group members can process those experiences and learn healing skills, coping skills as part of a community of survivors. And also, emergency crisis counseling is important as well because it can help a survivor gain back basic stability in their healing journey when they need to. Things like self-care practices, like art, exercise, mindfulness, yoga, journaling, and those are just a few things that can all be integrated in with therapy as well. Other helpful approaches include couples therapy and family therapy because they strengthen healthy relationships and they strengthen support systems. And also, we know that secondary and generational trauma are real, and those survivors need the support as well. So, all of these approaches, plus a bunch of other ones I didn't even name, help build resilience by strengthening resources one could have in their healing toolkit after, an assault or going through violence. Yep.
Thank you. Thanks for that, Andrew. Lauren, how can survivors be supported in developing emotional safety plans, self-care routines, and personal boundaries?
Yeah, so I think it's really important first to meet them where they're at, and encourage small steps. So immediately after, or even weeks after, a trauma like domestic or sexual violence, a self-care routine that someone might be putting in place isn't necessarily going to be a full-fledged skincare 5-step routine. It's going to be it might be at least going back to the basics of making sure you wash your face and brush your teeth every day, or just eat today, and things like that. So meet them where they are, because if they're struggling with those things, coming in and suggesting that they start meal prepping and going to the gym or things like that just are not going to necessarily seem like something that they feel like they can accomplish until they're into more of doing some of the other things along the way. Another thing in terms of the developing emotional safety plans is to just remember that the same way that survivors know their physical safety the best, they also know their emotional safety the best. So it can be easy to, from an outside perspective, offer solutions to, especially maybe like with domestic violence, if someone's getting harassing text messages, it might seem like their emotional stability and everything would be better if they just blocked that person, but they might also know that their anxiety about what that person is doing now that they blocked them and they aren't able to see it anymore is so much more severe than any of the stress that they were experiencing from the text that they were getting. So just the same way that survivors should be leading physical safety plans, they should also be leading the emotional safety plans. And they know themselves best and how things feel to them and what feelings stress them out the most as well. And it might be different than it would be for us. And then the last is just within your relationship with them, mirroring self-care and protecting your emotional safety and maintaining boundaries just throughout your work with them. Mirror the fact that you're doing self-care and things like that, and that you prioritize mental health, and just show that through your own life as you work with them as well.
Yeah, so many moving parts there. I just like the example that you used of depending on what's more comfortable for them, whether it's receiving these texts that stress them out or not having any contact at all. And so as it must be hard to just not tell them, just block them, because that's what I would tell my girlfriend. I would say just block them, but you have to, it's a totally different mental space. So thank you so much for sharing that, Lauren. And so Mariann, this is I'm going to ask you to give what we call the lay of the land. We don't want everything to be poo-poo. We know we got some changes coming up with Medicaid, but just where are we right now in this space, mental health, DV, SV services, and mention the Medicaid cuts that are coming in, what that can mean.
Sure. And I also want to just touch on what Lauren was saying, because it reminded me of a woman I recently spoke to who, again, the experience of trauma can also be developmental, and our relationships with people change over time too. So like even when the calls stop, it can also be other things further down the road that occur that bring that trauma back up. So these needs that people have related to their experiences of violence and trauma are real, and so much real that we have for decades been able to access services because of the parity with medical help and mental health work. We've been able to access services and support through the use of Medicaid. Medicaid is a provider of insurance here in the state to many people who seek services. And so many folks are able to get the therapies that Andrew and Lauren were describing in our community with our community providers, and it ensures that those services are around. But we do anticipate at the federal level, because of the big, beautiful bill and some additional changes that have been going on with funding in the current shutdown, we are anticipating here in Delaware that there's going to be ripple effects through our mental health and service systems with the changes in Medicaid and access. And so here in Delaware, we just last week were meeting with mental health providers from across the state and the Division of Substance Abuse and Mental Health and members of the General Assembly to talk about what we can do to shore up Delaware's safety net and what it's going to take in order to make sure that as these federal cuts and impacts happen, what we can do here in the state. And so we do expect that there's going to be shifts and things are going to be ended, and programs that might have been servicing people are going to have to perhaps decrease staff. But even more important than for us to stay connected and continue to work to make sure that as providers in the state, we know who's doing what. Like just again today, hearing Andrew talk about the CBT services and the support groups that you offer is spectacular, because that isn't necessarily Medicaid payment dependent, right? So, and I know that you're always saying we would love to be able to connect with more people and have more referrals. So I really do think that as we look at the impact that these federal cuts might have here in Delaware, that we get even tighter on how to make those referrals and connections to folks like you. So but that means we all have to stay in communication and be sharing things on our socials and what the latest services are and how we can help.
Yeah, just in case things change up. Thank you so much for that. That's so we have really speedily gone through this. So grateful. So we are, after we do our final question, we're going to open it up from questions to the audience. I hope that's okay. But finally, I would just like each of you kind of to touch on what gives you hope in this work, and what do you want the audience to take away from today's conversation? And we can go in whatever order you'd like. I can call on you. Mariann, you want to go first? Great.
I'm going to call out, I'm the oldest person in the room, so I'm going to try to start us off with good hope, because for folks who know me, they know that I've been working here in Delaware for a good long time, trying to create social change and bring some hope to our communities. And so I continue to do that. And part of what has recently really been energizing me is getting connected back with people in our community. I've had the pleasure of doing outreach events and community trainings and working with different groups. And what I continue to see and continue to experience are well-meaning and well-intended, hardworking people like us in this room right now, doing this stuff and who believe in this. And I see it also in the sharing of connections. We have always known at the grassroots that it is our connection that gives us strength, and that we will be able to, by continuing to do work like this and being able to build as we have over the last 50 years of my life, continue to build that, because I see the people in this space today. But the other thing that gives me hope in this work is that I mentioned the advances we've had over the last 20 years, just in neurological science alone, in understanding what the impact of early childhood negative experiences are, what the impact of complex trauma can be for mental health. And it's been so refreshing for me to be exposed to some of that cutting edge work on serving individuals with complex trauma. We do a lot of work at NAMI Delaware, doing engagement with veterans. And at the same time that we know the trauma that they're experiencing has been horrific, the field continues to try to find ways to help support them, and are finding innovative strategies and methods that we didn't even consider years ago. You know, the use of things like transcranial magnetic stimulation, which used to be this hokey kind of science, really is showing a lot of positive results for folks. And EMDR being another one of those strategies. And so it gives me hope, because we as a field and as a community of advocates continue to advance it. We're not staying in one spot. We're continue to move the ball. It is a huge ball, just saying.
Yeah. Yeah. Thank you so much for that. That's Yeah. Well, thank you for what you do. I'm going to just go to Andrew because you're next on my screen, sir, if you'd be so kind.
All right. Yeah, so one thing that's giving me hope is, I've worked with a lot of people who use services like SARC and, also their personal support systems to get what they need and process after surviving sexual and domestic violence. And almost all these people stabilize and most go on to thrive, right? So it's always rewarding as a counselor to encounter a former client later down the road and find out they're doing pretty well and, they're living their lives and, you know, they've, you know, they've they've got their sense of self back and they feel like more than just what happened to them. Um and I want the audience to take away, that there is help available. Survivors deserve support whether their experience is recent or it happened decades ago. It can still have effects that pop up again or just pop up for the first time a long time after the incidents happen. Um, Even if not professional, loved ones and community members all can play helpful parts of being in a support system for survivors, whether personally or like systemically. And yeah, overall, survivors can and do heal from the effects of domestic violence and sexual violence.
So your hope is in the healing. I love it.
Yep.
Um, okay, Mariann, you're next, but you already went. So Amma,
I think what gives me hope is the resilience I see every day, resilience from survivors, from advocates, and just all over the community, how we continue to show up for one another despite the challenges and the changes that occur. And so I think that also is something that I hope everybody takes from today is that, we work together. We're a community of advocates, of survivors, and through that relationship building and through staying in communication and in connection with each other, we can continue to fight whatever might come our way, to come up with creative solutions, to alleviate any issues or disparities that we face. And so just the resilience, just us showing up and knowing that good days will come. We have bad days, but good days will always come at the end.
love it. Resilience. All right, Lauren.
I think I'm kind of touching on a few things that you guys mentioned, but I would say what really gives me hope is just the people in the field and victim services at the YW, at SARC, everyone that we work with, and just knowing that so many people care enough to show up every day and do this for work and are really passionate about it and are willing to keep showing up even when things consistently when are getting kind of harder and there's more clients and everything. So I think it's just been inspiring seeing that and just the creativity and resourcefulness that I've seen come from it, the ways that people are coming up with new ways to help survivors and to meet those needs in the new climate. And then I think the takeaway I would want people to have is just that in our work or our personal lives, how we respond to disclosures of domestic and sexual violence has a really big impact on how survivors are able to heal and move on from it. So if someone's willing to have that conversation, whether it's again through work or just someone that you know, it's so important to respond to them with the full belief and reminding them that it's not their fault, and that they didn't do anything wrong. And just there are so many voices, both probably in survivors' head and also in our community and in people's responses to them when they disclose, that are telling them that they may have done something wrong, or that they, for some reason, that this happened to them specifically. So there just need to be more voices reminding them that that's not true.
Thank you for that. So many words. I'm just like, what, you know what? One of the things we didn't talk about, I'm trying to see how much time we have. It's 20 minutes. I'm going to throw this out there, but I want to talk a little bit about prevention. And I want to talk about prevention in the space of, you know, childhood experiences and mental health. Does anybody want to step in on that one? Just a little bit about the things we can do. I know,
So, yes,
Mariann,
I'm
I know you
happy.
have an answer for this, so.
You know I do. You know I do, because I am all about prevention and early intervention. And there are some really good programs and ways that we can support young people who experience things in early life. And I didn't get into the whole discussion earlier of the risks that are associated with substance use disorder as well, and how stigma, unfortunately, is one of those pieces that continue to drive people not to identify as having a mental health challenge and not seek help because they themselves have difficulty acknowledging that they have something going on. And so it really is important. And Delaware has made some really good strides at trying to integrate mental health supports and resources within our education system, our elementary and our high school systems. But it's like adding a drop of water into the ocean. But at least that drop of water is in the ocean, right? So, but we need to do, there is so much more that we can do to provide children and youth with skills to be resilient in a toxic world. Again, we recognize that the world isn't necessarily a safe and stable place for everyone. So how can we make sure that all children have social and emotional resources and support so that they can understand also the technology aspect of what's coming at them. There's so much we as adults don't know that our children are being exposed to in that video world. So being able to build more resilience for our youth is certainly something that in the long term will help everyone. And I know that the YW and I know that the DCADV and others are doing programming in that area too.
Thank you so much for that. It looks like we missed one question. Did we do question 8? What does it mean to implement trauma-informed practices in mental health? No, we did this question. We did that question. That was yours, right? We covered that.
I think we kind of covered it in other answers, but I can talk a little bit more about it.
Yeah, why don't you go ahead? Just what does it mean to implement trauma-informed practices in mental health and survivor support services?
Of course. So when we talk about implementing these trauma-informed practices and these support services, we're really talking about how we shift, how we think and interact and create these caring environments. And I think it really starts with understanding how trauma is widespread and how it affects the way people see, relate to the others, the world, and engage in services. And so being trauma informed means moving from the mindset of what's wrong with you to what happened to you. And even further, acknowledging the strengths that they have to navigate society. It's also about recognizing the impact of trauma and avoiding traumatization, and also creating safe spaces that emphasize that safety and trust and empowerment that we've talked about today. And so in practice, this might be being more transparent about processes like Mariann spoke about with confidentiality and mandatory reporting, but also giving clients real choices, being mindful of power dynamics, right? What Lauren said, acknowledging how, they might not be able to block somebody, or if they do, what, on the other hand, what will that cause in a person? It also might be thinking about how you support your staff, right? Because sometimes we can't offer trauma-informed care if we're overwhelmed or unsupported. And so I would say it's really about looking at the whole person, not just their symptoms, right? And then creating those systems that can promote that healing and resilience. And then tying it back to the question that was answered in the Q&A, do you have tips of how to support a survivor who might be dealing with trauma and abuse rather than a diagnosed disabilities? What services do you recommend coordinating with? I would say again, right, when you're working with a survivor, you're going to acknowledge what what they're going through, what they've gone through, and connecting them to the services that exist already is a great start, right? So connecting them to support groups like Andrew mentioned, getting them involved with the domestic violence community health worker program to help them navigate those health needs that they might have that as a result of their abuse or trauma that they've gone through. Go ahead, Mariann.
Yeah, well, and I think, because you've gone into the question about the housing piece, and I saw that question from Nick as well. I think the other piece is that, again, I mentioned stigma a moment ago, but stigma is one of those things that for survivors of domestic violence and sexual violence is a real concern. Again, their credibility may have been challenged. They might have experienced people accusing them of having a mental health condition, but now they're actually experiencing anxiety or depression or paranoid thoughts that could benefit from care and support and services. So it's also getting that mental health care that people need. And what I'm learning is that we have many individuals who don't want to have a label of disability because of also the stigma that's associated with that. And so I think really when we are working with individuals that we have to remember that even that we have to look at each person and just know that we might have worked with 300 people that have experienced domestic violence and homelessness, but that's just 300 people, and this person in front of you is the 301st. And so you have to take a fresh view and really look at what are the services and supports that this person needs. Because everyone's going to have different needs in that circumstance. And I do know that the Classy programs do a great job with advocating for people, but if the person doesn't have a disability diagnosis, then clearly that's an issue. But if it's because of the stigma and concern or because of the lack of access to adequate care to say, yes, actually, this is a diagnosed mental health condition and you've been getting great advocacy and support by paraprofessionals, but a mental health professional really needs to take a different review and perspective on the case. I encourage people to seek those services out. Frequently in Delaware, we talk about how, well, there aren't any services that offer that, but we actually do. And again, getting connected to those services and support may take some doing, but our agencies and your agencies are there to try to help get people connected to support. So also, Nick, you know how to reach me, so happy to connect offline.
Thank you so much for that, Mariann. Lauren, I'm going to hopefully ask you something. I would like to share about what our SARAs do, what a SARA is, and kind of the training, because we're always looking for individuals that are willing to do this work. Are you cool with doing that?
Yeah, definitely.
Awesome. Awesome. Thank you so much.
Of course. So with SARC, one of the services that we offer, we have our 24/7 helpline that's actually entirely volunteer run. And our volunteers are amazing. And they also accept accompaniment requests for both legal and medical accompaniments, but most commonly calls from the local hospitals that have sexual assault nurse examiner units who have a patient that's come in after a sexual assault or domestic violence incident that is seeking a forensic exam and medical care. and our advocates will actually go and respond to the hospitals and provide emotional support and get them connected to resources, and make sure they have a place to go that night and they have transportation and things like that, and help them answer any questions they might have.
What does that training look like? Like if somebody wanted to do it? Yeah.
So if someone wanted to do it, email me, or you can call our helpline, or anyone at SARC, really, you can email. But typically we'll have a training class that is scheduled based on people's availability. So depending on who's in that, but we go over everything from DVSB 101 to specifically like scenarios you might encounter at the hospital, and what you might, different things you might want to do in those situations, as well as reporting on, or as well as training on crisis intervention, and
How long is the
just-
training?
um
Like is it a certain number of hours, like 40 hours or something?
it's 15 is hours, and then there's a 40-hour online
Okay. Okay.
module, but we might be switching that a little bit.
Yeah. I know we got some changes. So for now, that's what it is. But if you are interested in that, our Sarahs are amazing. They do it from the deepest well of their hearts, I have to say.
They're incredible.
Yeah.
And we
Yeah.
could not do it without them.
Absolutely. So we have a couple questions. First one, they're a counselor in training. What are some of the challenges they may face as a new counselor providing services for individuals who have experience? DASA. I'm going to go Google what the right term is right now. Is it SBSA? So have experienced DASA.
Yeah, so for new counselors, I guess the immediate thing I can think of is like the like human urge to want to like jump in and do everything for the survivor. You'll learn the balance of doing what you need to in your role to support the survivor. Oh, sorry, I thought my connection dropped. The balance of doing what you need to support the survivor in your role as a counselor, and also like how to also empower them by having them navigate other relationships with other professionals or people in their life. Um, but I also want to like I think a part of that solution is also doing some of this systemic work and networking that Mariann was talking about with other service providers and other like people working locally in your field. So that's how you still help the survivor get their needs while understanding your boundaries as a counselor.
Thank you. Thank you so much for that. I imagine it's definitely challenging. Thank you, Denise, for going into the field. Um, um, Maria's question is, do you offer any services that will help someone who have a past experience of sexual assault to better heal, to better understand and heal? That might be you too, Andrew. So basically, I think what they're asking is if it's been a long time for them, are services still available?
Oh yeah. Services at the YWCA don't it doesn't need to be for a recent event. We commonly people come in years or decades after. One common thing I've seen is like people who survived sexual violence a long time ago, they're getting married, and that's a common time they need to navigate. That can happen, a long time after an assault. So yeah, I think that's services are open to anybody. Um, it just has, as for at any point in the lifespan, they've experienced sexual or domestic violence.
Thank you. All right, let's see.
And
Thank you. Go ahead.
I also,
Please.
because I think this is a really important piece. Again, there are generally 3 legs to a stool that support people in their recovery. And that might be some medication help, that might be some counseling, but we know connection to supportive and trusting communities is the 3rd leg to that treatment method. And so, especially for people experiencing mental health, it's really important to have that connection to support group. And Andrew's right, like people can come in and out of these groups, and Delaware is working to try and build more of a recovery and support model for people generally. I was just visiting the Recovery Cafe on Union Street that's run by Impact Life, and Teddy there shared with me that they're going to be starting a trauma group once a month, again, because they have lots of folks who want to be able to connect and learn more about how to cope with their trauma, and find a community of support of people that can build connection around that. And so I encourage providers to make sure that they don't feel so isolated, and they know that there are folks like us out there running groups. NAMI Delaware offers free support groups. The Mental Health Association offers free support groups. And so helping people keep those connections, I think, can really help.
Thank you for that. And for everyone, I'm going to share a slide. Actually, I'm going to go to that now. We might still be able to answer some questions with the. Oh, thank you, Andrew, for answering that one right in the chat. There's no cost if anyone else is reading that for SARC services. See if this works for everyone.
Yeah, if anyone's interested in any of the SARC services, the best way to get connected is to just call our 24/7 helpline.
Yeah, and so up on the slide here, I'll send this slide out as well. Everyone who registered for today will send out the recording. Eventually it'll be on our YouTube channel as well if you'd like to share that. But we will also, again, like I said, send out this resource. I think if you call any of these numbers, if they don't specifically have what you need, they absolutely know where to send you. So just wanted to make that note. I really want to thank you guys for being here today, sharing your time and your stories. I'm also aware that there's a lot more of a deeper dive that we could do on this. And we just kind of broached some topics here and there. But like Mariann said when we were discussing earlier, is we could have one of these on each and every question. So look forward to that. We might do some more of these. So I'm going to stop sharing only so I can get you guys back. All right. Wonderful. Thank you. Thank you all for being here. And thank you, my wonderful panelists. You guys did a great job. And now you guys can go eat lunch. All right. Bye.
Thank you. Have a good one.